Hi, I'm Robert Byrne from the Deutsches Herzcentrum in Munich, Germany. It's a pleasure to be here at ESC 2011 in Paris, France, and it's a pleasure to be joined by Dr. Shiomi from Kyoto, who's just presented some very interesting findings relating to the CREDO-Kyoto PCI CABG registry, and this is in fact cohort 2 of patients that you're looking at here. So welcome and thank you for coming here today.
Oh, thank you.
Maybe you could tell us a little bit about the background to your study and what question you wanted to really address with the current analysis.
Okay. As you know, PCI has been widely performed for severe coronary artery disease, such as left main disease or triple vessel disease. However, long-term outcome of PCI relative to CABG surgery have not been adequately established yet. And recently, 3-year results from Syntax randomized trials suggested that excess risk of PCI relative to CABG surgery was significant in terms of all-cause death and the safety endpoint. There is a composite of all-cause death, myocardial infarction, and stroke. And they also reported the different outcome according to the severity of coronary anatomy represented by Syntax score. However, the limitation of this observation was lack of statistical power in evaluating hard endpoint. So we conclude the current analysis to evaluate the long-term clinical outcome of PCI relative to CABG in patients with triple vessel disease in real-world clinical practice in Japan.
Okay, so this is a registry of patients that you enrolled over what type of a time period?
Yes. CREDO-Kyoto PCI CABG registry cohort 2 is a large-scale cohort in which 26 Japanese centers participated and enrolled more than consecutive 15,000 patients, 50,000 patients who underwent first coronary revascularization during 2005 and 2007 after approval of drug-eluting stent in Japan. And of the entire cohort, we identified 2,981 patients with triple vessel disease, and in which 1,825 received PCI and 1,156 underwent CABG surgery.
Okay, tell me a little bit more about the PCI patients.
Yes.
What type of specific therapy did the PCI group receive?
In our registry, drug-eluting stent was used in 77% of the patients in the PCI group.
Okay, good. So what did you find? What was the main findings of the current analysis?
Yes, the primary outcome measure of the current analysis was a composite of all-cause death, myocardial infarction, and stroke up to 3 years. PCI was significantly associated with higher risk for a primary outcome measure up to 3 years, and its adjusted hazard ratio is around 1.4 in entire cohort.
For the entire cohort.
And about survival outcome, the incidence of all-cause death was also higher in the PCI group compared with CABG.
Okay.
And about myocardial infarction, the protective effect of CABG relative to PCI for myocardial infarction was particularly remarkable.
Okay, so I think you should be congratulated on choosing an endpoint then that takes TLR out of the equation, because I think in comparing CABG and PCI, it's often better maybe just to examine the hard clinical endpoints relating to mortality, MI and stroke, and then afterwards to look at TLR. Was there any, what type of signal did you see in relation to revascularization or TLR?
TLR? The risk of repeat revascularization was markedly higher in the PCI group despite of dominant use of drug-eluting stent in this cohort. The cumulative incidence of any coronary revascularization in the PCI group about 40% against about 10% in the CABG group.
Okay, and how did the findings in relation to the primary endpoint then differ across the Syntax score tertiles?
Yes, that is the important point of this trial. We calculate the Syntax score in 94.3% of the patient population, study population, and we perform the stratified analysis by the Syntax score to overcome the limitation regarding the comparability between PCI and CABG. about the severity of coronary anatomy. And include analysis, unadjusted analysis. The cumulative incidence of primary outcome measure, death, MI, and stroke up to 3 years, was not different between the treatment groups in patients with low or intermediate syntax score, while in patients with high syntax score, it is markedly higher in the PCI group.
Okay. So interesting findings in relation to the syntax score.
Yes.
How does this fit with what we already know from the studies looking at the syntax score tertiles in terms of outcomes?
Yes. However, after adjusting potential confounding factors, PCI was significantly associated with higher risk for primary outcome measure, even in patients with low syntax score. This is a point inconsistent with the syntax randomized trials. So I think the selection of revascularization strategy in triple vessel disease patients with less complex coronary anatomy deserves further consideration due to discrepancy between the result in our study and the in the syntax trial.
Okay, very interesting. So do you think we should all be measuring syntax score in routine clinical practice to guide our decision making?
Yes, that is the most important point. And I think the syntax score has the utility of the risk stratification in patients with triple vessel disease, because in patients with high syntax score, consistent with the result from the syntax trial, the superiority of CABG surgery was apparent.
Yeah. Okay. Well, Dr. Shiomi, congratulations on conducting an excellent analysis from this cohort 2 of the CREDO-Kyoto PCI CABG registry, and we look forward to reading more details about this, hopefully in the future.
Thank you.
Thank you.